Welcome. My name is Karen Curry, and I'm the president of Community Health Nurses of Canada. So really warm welcome for you coming to this webinar here this afternoon or morning, maybe where you are from. I would encourage you to acknowledge the traditional land on where you are sitting. I'm presently in Halifax, Nova Scotia, which is the traditional unceded land of the Mi'kmaq people. I have the privilege to live, work, and play on this beautiful land, and lovely picture of the fall colors are showing all their glory here this week in Miyamaki. We also encourage you to, in the chat, to share any questions. And if you see friends that you know from across the country or different units, please communicate and chat that way. Want to take this opportunity to let you know a little bit about CHNC. If you're not aware, we are the Community Health Nurses of Canada, community organization, nursing organization, professional organization as part of Canadian Nurse Association. Currently, we have close to 300 members. We're a small but mighty team, and certainly we want to be the voice of community health nurses in Canada. So if you have been a member in the past or you're thinking about membership, please connect with us. We currently have 10 active standing committees that are doing the work of association work, policy work, of advocating, promoting membership, certification, research, and policy. So I want to thank you from all the members on the board and the committees that you're joining us here today. I really want to encourage you to consider your professional development, thinking about coming to our conference in Toronto in April. Our conference is April 22nd to 24th. Our theme is Community Health Nurses, Health for All, and the call for abstracts is currently live. So the website here is posted, chnc2024.ca. You'll find more information about the abstract submission process, and that is due on November the 15th. So I know you're doing great work in your programs, in your communities, and we'd love to have you share that and become engaged with Community Health Nurses of Canada. So some of the objectives of what we do as an organization: we want to advance the health of people in Canada. We want to strengthen CHNC as a center of excellence for community health nursing. And we want to help support and maintain an effective organization to meet the changing needs of community health nurses across public health, home care, and family practice nursing. Like to take the opportunity to draw your attention to our infographic, which talks about the standards of practice of CHNC, of community health nurses. We're also doing some work in this year to update our home health competencies. And I'm currently involved representing CHNC with the Public Health Core Competency Modernization Project that Claire Vector is leading, and other prominent public health researchers. They're currently doing their roadshow to consult with the modernization of the core competencies, and CHNC will be hosting some webinars for that consultation in November. So if you'd like more information, make sure you're connected to see when the core competency work is coming to your area, or as well jump on one of the webinars that we will be hosting. We want to have as many public health nurses give their voice to this public health core competency work. Please see our website and our socials for more information. We do a Facebook group. We also have Twitter, Instagram, and LinkedIn. So there you'll find pertinent details about any upcoming webinars, conferences, and opportunities to participate in research or share your voice to growing the work of supporting adequate quality professional practice for community health nurses in Canada. So the reason why we're here today, thank you, on October the 25th, we're here to talk about RSV, the burden of disease in infants, and the use of the preventative strategy. Really like to thank our presenter, Erin Fleischer, an NP, who's doing a lot of work in this area, as well as thank you to our sponsors, Pfizer, Merck, and Sanofi. This is part of our sponsored webinar series to engage and promote professional practice with community health nurses. I have Erin's bio here. She's a pediatric nurse practitioner at Children's Hospital, London Health Science Centre. She completed her Bachelor of Science in Nursing at the University of Victoria, went on to complete her Master's in Nursing and Acute Care Nurse Practitioner Certificate with the University of Toronto in 2009. Erin has been a nurse practitioner for the Pediatric Respirology Division since 2011, where she built and runs a centralized RSV prophylaxis clinic. Her other areas of clinical interest are childhood asthma, for which she's a certified asthma educator, pediatric cystic fibrosis as well. Erin is very active in research and participated in the CARES registry, Canadian database, which followed infants receiving RSV prophylaxis. So thank you so much, Erin, for taking time out of your busy work, and it certainly is that time of year, respiratory viruses circulating around. We're really happy to have you here today to speak to us. So I'm going to stop sharing and let you share your presentation.
All right, let's get this up. Can everybody see my presentation okay?
Yes, we can.
Thank you. All right.
So much.
Perfect.
Thank you, Erin. Looks good.
Thank you. Thank you very much for that introduction, Karen. And thank you for having me. I am very excited to chat with all of you today about RSV disease in infants and the potential immunization strategies that we could utilize. It's not often in this area of disease that we get to say it's an exciting time. You know, RSV can be very devastating, but we do have lots of new immunoprophylaxis and vaccination advancements that have been occurring over the past few years, with a few coming to market within this past year. So things are changing rapidly. I know that last month there was a presentation that was given with respect to adult RSV immunization that is now available. So there may be a little bit of overlap with respect to what you learned in that presentation and what I will be discussing today, but hopefully, because I'm going to be focusing specifically on the pediatric population and those under the age of 2, hopefully this will all be new information for you. If you can put all of your questions into the chat or just save them to the end and unmute, that would be great. I'm hoping that we've got lots of time to have a good discussion and answer questions at that point. And I'm hoping that I've been pretty thorough in my my presentation so that we can answer all of your questions for you. These are my disclosures that I have. So the objectives of this talk, we are firstly going to understand what the burden of RSV disease is for all infants by reviewing the epidemiology and clinical factors for infection. We're secondly going to review the current and emerging RSV prevention strategies with a focus on passive immunization with Nirsevimab. And then lastly, of course, what the role and impact that nursing professionals can have on the management of RSV in infants. So first, we're going to talk with respect to what RSV or respiratory syncytial virus is. So as you may know, RSV is a member of the paramyxovirus family. This virus enters the respiratory epithelial cells at the F protein or the fusion protein. Once the virus invades these cells, it goes on to create inflammation, edema, and syncytial formations. A syncytial formation is just a large cell-like structure that's comprised of 2 or more cells. Eventually, these cells will slough off and into the airways and create more edema and swelling within the airways, causing that respiratory distress. The RSV virus is a very highly conserved virus, so we don't typically tend to see a lot of change with respect to what it looks like from season to season. There are several strains that are out there, but the two major strains that circulate with each viral season are subtype A and subtype B. And I know we used to subtype our RSV viruses here at the hospital I work at, but we no longer do that. I'm not sure if that's something that's done across the country at other hospitals. The F protein is an important part of this entire discussion, as this is the target for both past, current, and future monoclonal antibody therapies, as well as vaccinations that may be coming to the market. As with the majority of viruses that circulate each season, RSV is primarily spread through community exposures, making the likelihood of exposure for a neonate incredibly high once they've left that hospital setting. RSV is exceptionally contagious, and those who are infected can spread the virus for anywhere between 3 to 8 days in length. The virus is transmitted through respiratory droplets, which are released into the air after someone coughs or sneezes. These droplets can also be passed through direct contact, such as kissing someone who is unwell. It can also be transmitted indirectly, which we'll speak about in a moment. Every virus has an R0 value. So this is the mathematical term that is used to indicate just how contagious or transmissible an infectious disease is, something that I'm sure all of you know about working in the area you do. Someone who's infected with RSV is expected to transmit the virus to approximately 2 to 8 people. So to compare, if we want to compare to the alpha strain of COVID, which was the first one that we saw, it had an R0 value of 3 to 5 people, while influenza has an R0 value of approximately 1 to 2 people. Indirect contact tends to be the primary mode of transmission for RSV. Dried respiratory secretions containing the virus can linger on any non-porous surface for up to 30 hours. This makes transmission of the virus through contact with a contaminated surface more probable, and can also possibly explain why we see RSV spreading so quickly within our childcare settings. This also makes reinfection more likely for children throughout the viral season. So we can have RSV infection not only once, but 2-3 times each viral season. With high rates of exposure and high infectivity, by the time we reach 2 years of age, we will all have had at least one RSV infection in our lifetime. While RSV circulates year-round, it does tend to be more seasonal. So historically, what we've seen is that the number of RSV cases will begin to rise in November, usually around mid-November, and last to the end of March, kind of into the beginning of April here in the Northern Hemisphere. There are, of course, some slight variations that we can see across Canada, with each province having a little bit of a different start and stop date to their seasons. And then, so for an example, Northern Ontario is quite different than where I am in Southern Ontario, in that they see a slightly later start to their season and end date for their RSV seasons. And this seasonality has always kind of dictated when the RSV prophylaxis programs are going to begin and end each year. To further highlight one of the seasonal differences that we see here in Canada, let's take Nunavik, Quebec as an example. RSV hospitalizations tend to start in January of each year, and they will last until June, thus making this 6-month time period when they typically have their RSV season there. When we're looking at our most recent viral seasons, we can see that in the fall of 2019, we saw a typical viral season with the expected gradual rise starting in December, peaking in early 2020. And then there was a decline with a rapid drop-off in March as pandemic restrictions were put into effect and RSV activity was abruptly ended. Interestingly, we saw no RSV activity during the 2020 to 2021 season due to those ongoing pandemic restrictions. However, as these were lifted and children returned to school, we saw a resurgence of not only RSV, but all viral activity. As you can see, there was a significant shift with cases occurring as early as August when RSV did come back. In both the 2021 to 2022 and 2022 and 2023 seasons, we saw that the peak incidence actually occurred right around Christmas time, right before the beginning of the new year. Modeling from Australia, where they have just completed their viral season, continues to show that we can expect an early, we can expect an early start again this fall with higher than normal activity. This is the case in Ontario, as we have just started to see children being hospitalized with RSV infection to our PCCU and inpatient units. And due to this, the Ministry of Health here has stated that we're going to be starting our immunoprophylaxis programs earlier this year than we typically do. So now that we know what RSV is, what does the data show us about the burden of RSV in infants? For the vast majority of us, RSV infection is similar to a cold with mild upper airway tract symptoms, which can consist of sneezing, nasal congestion, and cough. Should the virus travel from the upper airway to the lower airway, it can then result in worsening symptoms. Those with severe disease can experience symptoms such as wheezing, tachypnea, hypoxemia, and even apnea. Babies may be diagnosed with bronchiolitis or pneumonia. Along with this, you can also see several non-respiratory symptoms such as fever, sleepiness, and poor feeding at any stage of the illness. Age can play a significant role in determining the severity of disease. Unfortunately, there's no way of knowing which individual may develop mild or severe disease, but we do know that the very young, and as you heard previously in the presentation last month, the very old tend to be at the greatest risk for severe illness. Due to the anatomy and physiology of an infant, this makes them particularly susceptible to more serious RSV disease. Their small airways, limited reserve, and reduced immune response can lead to them developing respiratory distress very quickly. For those children who are admitted to hospital due to an RSV infection, their treatment options are limited to supportive care. Some infants may require supplemental oxygen via low-flow nasal prongs or heated high-flow nasal cannula. A few patients may go on to require non-invasive ventilation, and worst case scenario, some may require intubation and mechanical ventilation. IV hydration and NG feeds may also be utilized. As referenced in the Canadian Pediatric Society guidelines, which were published in November 2021, there is no good evidence to say that medications such as salbutamol or oral corticosteroids are effective in treating RSV bronchiolitis. It is hypothesized that after an RSV infection, there can also be long-term complications such as recurrent wheeze, asthma, and decreased pulmonary functions. The INSPIRE study, which was recently published in The Lancet in April of 2023, followed approximately 1,700 children over a 5-year period. They found that in those children who'd been infected with RSV in the first year of life, had a higher likelihood of developing asthma when compared to those who did not. These ongoing health concerns could lead to continued healthcare utilization for years to come. So now let's speak to the burden of RSV disease on the healthcare system. Worldwide, RSV is the most common cause of hospitalization due to respiratory illness during the first year of life and affects infants from across all demographics. Looking at the data here in North America from 1997 to 2000, so this is a little older data, but it still holds true. In the United States, it was seen that RSV was the leading cause of bronchiolitis in those infants being hospitalized under 1 year of age. Because they do not routinely test for RSV, there is belief that the burden of disease is actually underestimated, and some of those patients admitted with unspecified bronchiolitis or pneumonia may have in fact been RSV positive at the time of illness. Not only do hospitalizations for RSV place a burden on the healthcare system, but outpatient visits to the emergency department, walk-in clinics, urgent care, and community practitioner offices accounts for up to 97% of medically attended RSV cases. This creates even more strain on an already stretched healthcare system. This was something that we all saw firsthand during the past viral season, with healthcare utilization skyrocketing, and some hospitals needing to create extra pediatric critical care space or putting up tents to manage the surge of patients presenting to the emergency department. If we look at our existing Canadian data, we can see a similar trend here as well. A retrospective study looking at infants under 2 years of age who were hospitalized due to respiratory illness between 2003 to 2014 found that those children were 14 times more likely to be hospitalized due to an RSV infection than for influenza. Data obtained from the Canadian Institute for Health Information, or CIHI, looked directly at children under the age of 5 in Ontario between 2009 and 2014. In that timeframe, there were just over 6,300 confirmed RSV hospitalizations in children of this age. Almost half of them had no identified underlying comorbidity at the time of their illness. Furthermore, of the 467 children who required ICU admission, again, close to half of those were healthy children. A retrospective chart review completed at the Children's Hospital of Eastern Ontario, again, also confirms this data. From 2005 to 2013, approximately 80% of infants hospitalized in that time frame with confirmed RSV infection were born at term and healthy with no additional risk factors, such as bronchopulmonary dysplasia, congenital heart disease, trisomy 21, or prematurity. To further delineate our Canadian data, it has been shown in multiple studies that those infants who live in remote northern communities, and in particular the Arctic, are at even more risk. Those infants under 1 year of age are 6.4 times more likely to be admitted to hospital due to an RSV infection than infants under 2 years of age in the remainder of the country. The reasons for this may be multifactorial and can include crowded living conditions, exposure to smoke, and poverty, to name a few. It is also hypothesized that there could be a genetic predisposition specific to the Inuit population. However, this has not been confirmed. Many of these infants will require significant medical support when they're unwell, leading to additional healthcare costs to transport them to a tertiary care center, where they are often hospitalized for a prolonged period of time. This creates stress and potential further financial instability on these families who travel to stay with their children. And again, if we look at data from Northern Ontario, specifically our Sioux Lookout Zone, admission rates for Indigenous infants under 1 year of age are 4 times higher than the rest of Ontario. There are some communities where that rate increases to 10 times more likely. And within this population, we again see that 93% of infants had no previous underlying medical comorbidities. So based on everything that we've just heard, is there then a need for us to have an all-infant protection? And what are the potential strategies that we could utilize to minimize RSV infection? As stated previously, the vast majority of us will have been infected with RSV by the time we are 2 years of age. Most people will only experience mild disease. However, we never know who may progress to severe disease, and even healthy term babies can be at risk of significant illness and possible hospitalization. Given this, providing protection to all infants could alleviate some of this burden. There are 3 potential strategies that could be utilized to provide protection. The first being a short-acting monoclonal antibody known as palivizumab that has been available for approximately 20 years. The second is a maternal vaccination known as RSV Pre-F. And lastly, Nirsevimab, which gained CADTH approval in April of this year. So let's just briefly speak about palivizumab. For the past 20 years, palivizumab has been the only RSV prophylaxis available to a very few select infants. Palivizumab is a short-acting monoclonal antibody that provides passive immunity. So this means we're introducing those antibodies against RSV into the baby's system, and those then circulate to provide protection. Given its short-acting, the immunogenicity wanes over the course of the month, which is why it's a series of injections over the duration of the viral season. Dosing for palivizumab is weight-based at 15 milligrams per kilogram, meaning that that dose is going to increase with each subsequent injection over the course of the season. Each 100 milligram vial costs approximately $1,600, and for an infant who receives all 5 injections, the cost for a total season could be at the very least $9,000. It is a cost-prohibitive and resource-consuming option, which is why each province has very strict qualifying criteria, and why for the vast majority of the provinces and territories, we run centralized RSV prophylaxis clinics so that we can cohort and batch as many of those doses as we can to try and save money for the healthcare system. As you can see, this current method has a low population benefit with only 2% of infants able to access the drug. With an all-infant approach, we can reach more infants and minimize burden of disease. Now moving on to the other two options. The first is the maternal immunization currently known as RSV pre-F. The pregnant mother would receive a single dose between 24 to 36 weeks gestation. She develops antibodies which are transferred to the fetus via the placenta, giving the neonate immediate protection at birth. Protection lasts for 3 to 6 months. The studies showed an efficacy of 82% at 90 days and 69% efficacy at 180 days against medically attended respiratory syncytial virus lower respiratory tract infection. There was one safety signal that has not been quantified yet, but does bode bringing up, and that is that there had been seen an increase in premature births for those mothers who were receiving the vaccination. As stated, the researchers have been unable to determine, though, if this is a direct correlation to the vaccination or if this was something that maybe would have just happened anyhow with those pregnancies. The FDA has approved RSV pre-F for this indication as of August 2023, and they've recommended that women who are 32 to 36 weeks gestation obtain the dose. This shortened gestational period was chosen due to that possible risk of prematurity. So the premature births were seen about 4 weeks post the immunization in the study trials. So by moving that dosing range to 32 to 36 weeks, then we're getting those mothers and babies closer to term pregnancies if that were to be an actual signal. By giving the dose at this time point, it would provide protection in the infants for up to 6 months of age. And currently we have an application pending with CADTH for approval here in Canada. While this is promising, there are some potential challenges with this strategy. First, we could see vaccine hesitancy among mothers leading to poor uptake, which I believe is a current concern with Tdap, which is also recommended during pregnancy. Secondly, the transfer of antibodies is optimal once the baby reaches full term, which means that those neonates that are born prematurely, so again, if a country was making that choice to go with the earlier gestational period, if babies were born prematurely, they'd be left with suboptimal coverage. And lastly, the timing of the birth may not coincide with the RSV season, again, leaving infants born before the start of RSV season with partial or no coverage. The second option is the long-acting monoclonal antibody, which we will be discussing next. So you may ask, why not give a traditional vaccine? As a neonate, they're not able to mount a robust immune response to a traditional vaccine. Therefore, they need to acquire those antibodies from an external source, either through placental transfer or be given those antibodies directly. So having said this, let's move on to reviewing Nirsevimab in the clinical data. Nirsevimab is a long-acting monoclonal antibody that was approved by CADTH and has a Health Canada indication for use in all neonates and infants entering their first RSV season, as well as children under 24 months of age who remain vulnerable to severe RSV disease. Nirsevimab works to bind to the F1 and F2 subunits of the RSV F protein, which blocks viral entry into the host cell, and is effective against both subtype A and subtype B. And this is important because previous attempts at making vaccines or other immunoprophylaxis were not successful because they were only effective against either one, like subtype A or subtype B. And some of those clinical trials showed that babies who ended up with, say, if subtype A was the type that they had efficacy against, if babies got subtype B, then they were getting very sick. And so some of those earlier studies had to be aborted because of that, and those and the adverse effects with that. So Nirsevimab is known to have a rapid onset of action. It provides direct protection against medically attended RSV infection. It's provided as a single fixed dose with an extended half-life to protect infants for the duration of the RSV season. And dosing is weight banded, with infants less than 5 kilograms receiving 50 milligrams, and those over 5 kilograms receiving 100 milligrams in a pre-filled syringe. So again, a much nicer form of medication and less having to worry about what the dose might be based on their weight. And additionally, it can be safely given at the same time as their other regular childhood vaccinations. Nirsevimab was designed to protect all infants against medically attended RSV, lower respiratory tract infection, and the clinical trials were designed to reflect this. So a phase 2b trial was performed as an efficacy trial comparing Nirsevimab to placebo in healthy preterm infants. The phase 3 MELODY trial also looked at efficacy comparing Nirsevimab to placebo, enrolling healthy late preterm and term infants. As part of the initial research plan, they included completing a pooled analysis, which combined study participants from the phase 2b and phase 3 MELODY trial, which represented an all-infant approach. Next, MEDLEY specifically looked at the safety of Nirsevimab and compared it to palivizumab. Preterm infants and infants with congenital heart disease and chronic lung disease who were eligible for palivizumab were recruited into this study. And finally, HARMONY is comparing Nirsevimab to standard of care in a real-world setting. As you can see, the study design for the phase 2b and phase 3 study were essentially the same with 2 exceptions. First, the phase 2b trial, all of the infants received only 50 milligram dosing, as it was also a dose-finding study. During the analysis, it was determined that for the heavier infants, this dose was less efficacious, hence the increase to 100 milligrams for babies over 5 kilograms for the remaining of the trials. Secondly, as mentioned before, the populations that were enrolled into each of these studies was slightly different. For both studies, all of the same endpoints were assessed, which include medically attended RSV lower respiratory tract infection and hospitalization due to RSV lower respiratory tract infection. By looking at medically attended cases of RSV, this reflects the impact Nirsevimab could have in an outpatient setting where the majority of disease burden exists. During the studies, if a patient were to become unwell, they had to meet the case definition for the lower respiratory tract endpoint. This included having a lab-confirmed PCR positive test, documented physical findings of a lower respiratory tract infection, and at least one medically significant clinical symptom as listed here. In the phase 2b trial, results show that in healthy preterm infants, there was a reduction by 70% in medically attended RSV lower respiratory tract infection at 150 days or 5 months post-injection. The trial also demonstrated a reduction in hospitalization for RSV lower respiratory tract infection by 78.4%, and both of these were significant findings. When we look at the phase 3 MELODY trial, Nirsevimab again demonstrated a 76.4% reduction in medically attended RSV lower respiratory tract infection at 5 months, and there was also a reduction in hospitalization by 76.8% in the healthy late preterm and term populations. Seeing efficacy this high against a respiratory virus is not always typical. When we compare to the influenza vaccine, it is known to have between a 30 to 50% efficacy, depending on the match for the season. Though this is not published yet, the pooled analysis of both studies, which represents that all-infant approach, continues to show that there is consistent efficacy against RSV lower respiratory tract infection with varying clinical consequence. So now that we've discussed what the efficacy of Nirsevimab is, what do we know about its safety? So the MEDLEY trial was specifically completed to look at the safety of Nirsevimab, and it was a head-to-head comparison with palivizumab. Participants who were eligible to receive palivizumab were enrolled, and they were randomized on a 2-to-1 basis to the Nirsevimab and palivizumab arms, respectively. While this slide's quite busy, it shows that all levels of adverse events that were both treatment-related and those that were not felt to be treatment-related. I'm going to speak to the top two categories shortly with respect to the adverse events. But as you can see, there were no treatment-related adverse events of grade 3 severity or greater. There were also no treatment-related serious adverse events. There was one reported adverse event of special interest in both Nirsevimab cohorts. However, it was felt that these were not treatment-related. One of these was a preterm infant who experienced a grade 1 severity hypersensitivity skin reaction, and this occurred approximately 3 months after their dose of Nirsevimab, and it was actually thought to be temporally associated with a placebo dose. The second was in an infant with congenital heart disease who developed a heparin-induced thrombocytopenia not considered related to treatment. There were unfortunately a few deaths recorded in both of the Nirsevimab cohorts as well as in one of the palivizumab cohorts. And these were well documented in the study findings, and again, not felt to be associated with the drug itself. So when we're looking at adverse events, these are any untoward medical events, even if they are not treatment related. So as you can recall on that previous slide, there were a fair number of adverse events listed in the first row there, but these were such things that were associated with having like a childhood illness. So things like vomiting and diarrhea that all children could have had within that time frame that they were being monitored post their injections. Within all of the trials, the most frequent adverse reactions, so that was the second row on that last slide that I showed you, the most frequent adverse reactions seen were rash, fever, and injection site reactions. The conclusion of the trial was that the safety profile for Nirsevimab was considered comparable to placebo. These side effects are also very similar to what we see in children who are receiving palivizumab as well. And while Medley was not an efficacy trial, the data did look at the incidence of medically attended RSV lower respiratory tract infection after 150 days of administration for both the Nirsevimab and palivizumab groups. What was seen in both groups is that the incidence of breakthrough illness was low for both cohorts in both treatment groups. Nirsevimab concentrations at 150 days in this infant population was comparable to healthy term infants enrolled in the phase 3 MELODY trial. This suggests that Nirsevimab could be effective in preventing medically attended RSV lower respiratory tract infection in both the preterm and groups of chronic lung disease and congenital heart disease populations. And finally, HARMONY is a phase 3 real-world trial that's comparing Nirsevimab to standard of care, which is no intervention in preventing hospitalization in healthy infants over 29 weeks gestation. The study design for HARMONY is randomizing participants on a one-to-one basis to both arms of the study with a goal to recruit 28,000 participants worldwide. The study started recruiting during the 2022 to 2023 season and will follow infants for a full 12 months. Study sites initially were primarily in the European Union and United Kingdom, as they had approval and access to Nirsevimab last season. Thus far, just over 8,100 patients have been screened, and of those, around 8,000 were randomized into the trial. Just over 4,000 participants have received a dose of Nirsevimab to date. This study is continuing to recruit, and thus far, no complications have been documented. HARMONY is currently only looking at RSV hospitalization data, and so far what has been shown is that the real-world efficacy is even higher than what they had seen in the phase 2b and phase 3 clinical trials. Here you can see that there is an 83% efficacy against RSV lower respiratory tract infection resulting in hospitalization. Interestingly, there has also been about a 60% reduction in all-cause lower respiratory tract infection hospitalization in those infants who receive Nirsevimab. This leads the researchers to believe that RSV may drive lower respiratory tract infection hospitalization And by preventing RSV infection, we can also reduce LRTI overall. So where are we seeing Nirsevimab being used? Nirsevimab was approved in the UK and some countries in the EU for the 2022-2023 season, as I mentioned previously. The UK has adopted a universal infant RSV program. In both France and Spain, they have recommended use of Nirsevimab in all infants under the age of 6 months for their upcoming season, which is starting now for 2023-2024. And Italy has opted to immunize infants that are born before and during the RSV season. In the United States, the FDA approved Nirsevimab in August of 2023. So we actually had our approval well before the FDA gave their approval, which is something that doesn't typically tend to happen when we're looking at new medications coming onto market. The FDA and their vaccine group down there have unanimously opted to prophylax all infants under 8 months of age born during or entering their first RSV season. They're also going to be offering a dose to those aged 8 to 19 months entering their second RSV season who are considered high risk for severe disease. Those children that they're deeming high risk include children with chronic lung disease of prematurity who require medical support in the 6-month period prior to the start of their second RSV season. So if they're still on chronic corticosteroid therapy, diuretics, or supplemental oxygen. The second category that's deemed high risk is severe immunocompromised children. Next would be children with cystic fibrosis who either have manifestations of very severe lung disease or those who are failure to thrive. And the last group that they deem to be high risk would be the American Indian or Alaska Native children. Here in Canada, after CADTH approved this immunoprophylaxis back in April, they created a rapid implementation advice document that was published in late July, and I believe it was July 26th to be precise. This document was created as NACI is not planning on releasing their statement until early 2024. The rapid implementation document provides guidance to each province and territory as they decide what product they're going to use this fall. CADTH opted to prioritize which infants should receive Nirsevimab prophylaxis, and they base this on a tiered risk group approach, which I've put onto the slide for you to look at there. Each jurisdiction has weighed this information, and at this time, kind of what I've seen and what I've heard from different people across the country that I've been in contact with is that most provinces and territories are opting to remain with palivizumab for this season while we wait on further information to come from NACI. So in summary, over 80% of children will be infected with an RSV infection sometime within the first 2 years of their life. RSV is the leading cause of respiratory hospitalization for infants, with the majority of those hospitalizations occurring in our healthy term infant population. There's a significant burden of disease that happens in the outpatient setting. And by considering and providing an all-infant approach, we can ensure that infants are protected against severe RSV disease and that unpredictable disease progression that may lead these children to require hospitalization and to seek medical care. Thank you very much. That is the end of my presentation, and I'll stop showing my slides now, and I would be happy to take any questions that anyone may have.
Thank you so much, Erin. That was an incredible presentation, very, very detailed, very in-depth. And I'm glad that we have this recorded so that people can go back. There's a lot of information that you've covered, very, very detailed information. And I'm going to open it up now. I haven't seen any questions that are put into the chat right now. And I'll just introduce myself to everybody. I am Barbara Chizzy. I'm the treasurer of CHNC, and I'm very happy to be moderating the question and answer period with us for everyone right now. So if there's any questions, either you can just raise your hand and we can take you off mute, or you can pop the question into the chat. Oops, sorry. Sorry about that. So while we're waiting for other questions, I have a question I would like to ask.
Yeah.
And so it was just regarding when you were talking about the adverse events and the deaths related to
Yeah.
The babies. And I know that obviously for, every people want to know the stats, and they're going to
Yep.
ask you as a nurse about risks and how and I understand when reviewing data what that means in terms of adverse events and temporal periods, and that there's not a link between that. But obviously you would never be presenting data in this way to to patients that you're dealing with. But
Yeah.
can you just explain a little bit about like what has been some of the feedback that you've been receiving from parents that when you've been speaking to them about the vaccines?
So with respect to Nirsevimab specifically?
Yeah.
Yeah.
Or
So
either of them, any of them. Yeah.
yeah. So I mean, clearly palivizumab is the one that I know the best, because it's been the only one that we've been using thus far. And I mean, we haven't been providing any information about Nirsevimab to parents as of yet.
Okay.
But there's parents that know about it. I mean, there's been a couple of older children with chronic lung disease who've been in, say, my RESP world, that are well aware of RSV and what it can do. Their parents who are well tapped in, and are asking about Nirsevimab. So if there are parents that are knowledgeable about Nirsevimab, they're doing their own research outside of us bringing it up, because we just haven't, not knowing which way the ministry was going to be going this season, and not knowing if we would have supply or any of those things, right? So, but when I'm speaking to my parents about palivizumab specifically, my quick spiel is, I talk about those symptoms that are the most common ones: the rash, the fever, the injection site stuff, and say that usually goes away within 24 to 48 hours, the same that it would with your regular vaccinations that you're seeing with your child. And then usually my next thing is to say, of course, none of us know how anybody will react to a medication. So if the reaction were going to happen, it would happen within the first 5 minutes, typically. Might be full-bodied rash, some difficulty breathing. They're here in clinic with us anyhow. So I just say, if it's happening, you're in a safe place for that to happen. And then, knock on wood, with palivizumab, I've never had a patient have an adverse reaction after the fact. Like, I've never had them come back to me and say, we developed rash several days later, or they developed significant difficulty breathing or an injection site reaction. So luckily, I haven't had to deal with that, because it's been a very well tolerated medication. But that's the conversation I usually have. I do have a few parents over the years where, they're very, they're maybe more scientific and they want that data. So I'll pull papers for those families that want it so that they can read. And I just make sure that they have the appropriate research documents and the best literature they can find, so that they're not going down some rabbit hole on the internet and getting inappropriate information.
Right. Exactly.
Yeah.
Okay. Thank you so much for that. I still don't see any other questions in the chat. Does anybody want to raise their hand to ask a question?
Or I was just that thorough.
You were that thorough. I think that, it's really, it's very interesting because, it's, really, I think that we're just starting this conversation right now, right? We're just, people are starting to think about how to have that conversation to understand what the new vaccine is all about. And so it's really been, I think that's, like, for me, that's a big takeaway. And I think that there's a lot of data that you've covered that I'm going to go back to and look at it again, because I know that I'm going to be having conversations with people going forward, and I can always refer them then to this video.
Yeah, exactly. And I mean, we're not doing Nirsevimab this season, unfortunately, the minute we're going with palivizumab. But again, my hope, again, with my respirology hat on, is that next year we will be moving towards Nirsevimab, and we'll be fanning it out in an all infant approach, hopefully, so that we're benefiting as many infants as we can and minimizing those risks of long-term potential complications, right? And if we are able to do an all infant approach, again, this is my opinion, this is my hope. But if we are, it's going to take all of us, right, to do this. It's not going to be right now. It's all on us as RSV prophylaxis programs because it's so small, but it really will be you, the community health nurses, it will be family physicians, it will be community NPs, it will be the nurses within the hospital who are discharging the babies, maybe even so that they're getting a dose before they go home. There's a lot of speculation about what this program could look like and how far reaching it may be. So you're right, the conversations are just starting, and it's very exciting.
Great. So there are a couple of questions now that are in the chat. So one of the question is to double check that you mentioned a 50% reduction in preventing LRTI overall, or did that person?
No, it was actually higher than that.
Okay.
Yeah, so we're sitting around 80% with respect to an overall reduction with Nirsevimab.
Mm-hmm.
Yeah.
Okay.
Yeah, so it's very efficacious.
Mm-hmm.
Thank you, Maggie, for that question and clarification. Other comments about great info. Thank you. Donna asked a question, will it be provided by public health nurses? And as a child would need to be weighed at the mass clinic?
Yeah, so again, this without knowing what the ministry is going to say with respect to Nirsevimab and what we may do in the future, I don't know. I would love to know how we may roll this out in the future, if it will be a mass clinic or if it really will be kind of all hands on deck, because there's lots of touch points for babies out in the community, right, across the country. And each province has their own little nuances with how their healthcare systems work. So I think each province will have to find the best way to reach the maximal number of babies that they can, and implement this in a cost-effective way as well, right? So unfortunately I don't have an answer about how that will be, who's going to give the injection if and when we get it.
Mm-hmm. Yeah, we'll have to have another webinar too once we have that information.
Yeah.
Sering asked a question. Can you please speak about some clinics waiting till 2024 for more information to start using Nirsevimab, even though it's been approved for use in Canada and some EU countries?
Yep. So that's specifically with respect to what each ministry of health in each province has decided to do for this upcoming season. So I believe, one, they want to see what the NACI recommendations are going to be with respect to this. I mean, yes, we had the CADIS recommendations, but I think everybody's waiting to see what NACI has to say. I think they're also waiting to see if we do get approval of that maternal vaccination. And then I've heard maybe doing a recommendation where it talks about the use of both of those and how that may work for this infant population. So there's that piece. And then of course, I don't know about supply at this point. We haven't heard about that. So again, really our hands are tied to what the ministries are deciding for us at this point, and how it's coming down. So all I know is that I've been told I need to run my palivizumab clinic this winter, and that's what I've heard all the provinces will be doing. So that's what we're forging ahead with.
Mm-hmm. Thank you. Yeah, that maternal vaccine really sounds interesting. That's the first time about that. So another question by Christine. Can this be given with COVID-19 vaccine? I guess both vaccines. Yeah,
that's a great question that I don't actually have an answer for. I know that we give flu vaccine with palivizumab. My assumption, if I can make an assumption, would be that yes, you could give it at the same time as a COVID-19 vaccination, but I don't know that we have any experience with that. I don't even know that I have experience with COVID vaccinations and palivizumab, to be quite honest. So at least my own personal experience, there may be other clinicians out there that do, but that I don't have an answer for.
Mm-hmm. Okay. Thank you. And then Brenda had a question. Thank you for a very thorough presentation of all the preventative therapies. Looking forward to an all infants approach and just one dose per season. So
yes, me too.
Mm-hmm.
Me too. Those second season babies, they are big enough that they get 2 injections and they do not like me.
Mm-hmm. Mm-hmm. So I think that's all for questions right now. And I thank you so much, Erin, for taking the time to talk with us today, for sharing your expertise, both the evidence as well as your practical expertise that you've been bringing to us today. So thank you again so much, and thank you to everybody who's joined us today on the webinar. It's a wonderful turnout again, and again, this will be recorded and posted onto the CHNC YouTube site. It takes a few weeks for us to get that ready, but once it's available, it will be posted onto the CHNC website. So take a look there, and you can find our other webinars that are posted there as well.
Thank you so much for coming, and we hope to see you at our CHNC conference and connect with you more. Have a great day. Have a great flu season, immunization season. It's that time of year. Take care, everyone.